Good evening, everyone. On behalf of classmate, I would like to welcome you all to Medcast, Insights into Healthcare, a learning initiative by Taskmate. Today, it's a great pleasure to have with us Dr. Nimmi Mulwani, who is a consultant diabetologist at Dr. Nimmi's Diabetes Care Center, Ahmedabad, Gujarat. We welcome you, ma'am. Ma'am, we look forward to hear from you on today's topic of discussion, therapeutic potential of dapagliflozin. Over to you, Dr. Nimmi.
Uh, just a minute. I'll just put my phone on silent so we don't get the call in between.
Yeah, ma'am.
Okay. Yeah, just done. Okay. Fine. Hi, I'm Dr. Nimmi Mulwani, and today we'll be talking more about a molecule which is very close to our hearts as a diabetologist. A group of medicine that we cannot stop prescribing, that is SGLT2 inhibitor. Since 2014, when canagliflozin was first launched, we started seeing more about this molecule. And after cana, we got empagliflozin, dapagliflozin. And since then, we are getting more and more positive results about dapagliflozin that we will be talking about today. We all know diabetes is a major health issue that has reached alarming levels. Nearly 500 million people are currently living with diabetes worldwide, and so many people, they are living with asymptomatic or undiagnosed diabetes as of now. Burden of diabetes has steadily increased over the last quarter century in India and across the globe, where India is contributing a major part of the global burden. Currently, we are at the world's second country to have the maximum number of patients, just beneath the China, but unfortunately, seeing the rising of the cases of diabetes, I think we will be surpassing China really soon. A day that we don't want to see. The National Health Policy of India aims to increase screening and treatment of 80% of people with diabetes and reduce the premature death from diabetes by 25% by 2025. We all know that Southeast Asia contributes 74% of the increase of diabetes cases in last century. That's a huge chunk. And it's a family of metabolic disorder characterized by hyperglycemia as a consequence of abnormalities in insulin secretion and insulin sensitivity. SGLT2 inhibitors, they are a relatively new class of oral anti-diabetic drugs, and they have garnered a considerable attention in the recent past, and now is potential first-line candidate for management of all type 2 diabetic patients. Recently, data that has been published have highlighted the benefit of SGLT2 inhibitors like dapagliflozin in heart failure and CKD, irrespective of the diabetes stature, and has emerged as a game changer medicine. More about the studies and the correlations we'll be talking today. We all know the normal physiology. Approximately 180 grams of glucose is filtered by our kidneys, and almost everything is reabsorbed back and sent back to the blood. The SGLT2 inhibitors lie in the proximal and distal tubules of kidney, so virtually no glucose is excreted in the urine. What SGLT2 inhibitor or a dapagliflozin molecule does is it reduces the glucose reabsorption by blocking the SGLT2 inhibitor. So there is increased glucose excretion and less reabsorption back in the blood. Hence, we receive a good HbA1c, a good glycemic control. What are the first things that we worry about when we write a prescription of any oral anti-diabetic agent? The most common side effect is hypoglycemia, weight gain, edema, and cardiovascular adverse effect. SGLT2 inhibitor works on all four. It causes minimum hypoglycemia, cause weight loss without an increase in cardiac events. No edema is there. It is CV safe. On the contrary, it helps us reduce the weight. There is a need of extra glycemic benefits, like the medicine should, have a positive effect on blood pressure, weight loss, lipid parameters. SGLT2 inhibitor have extra glycemic effects on BP. It reduces the systolic blood pressure. It helps in weight loss, and it normalizes the lipid parameters. It reduces the BMI as well. The beta cell dysfunction progressively increases, and treatment effect, which we call glycemic durability, it declines with time. So the medicine becomes inactive at the same dose after long term. So the patient needs more and more medicine over time. Action of SGLT2 inhibitor does not depend on beta cell. It is independent of pancreatic function. So the glycemic durability stays the same, and it helps us to reduce the complication of diabetes. We all know that failure of sustained glycemic variability leads to dysglycemic legacy of diabetic complication. There, as the years go on, the HbA1c keeps on fluctuating, and the patient develops first micro and then macrovascular complications affecting eyes, kidney, brain, nervous system, heart, etc. When we talk about dapagliflozin and glycemic durability, patients, this is a very good study that was done with patients with type 2 diabetes who were inadequately controlled with maximum 1500 milligram of metformin per day. They received either dapagliflozin 10 milligram or saxagliptin 5 milligram per day. So they are given either SGLT2 inhibitor or a DPP4 inhibitor. A low coefficient of failure, it values indication of greater durability, and coefficient of failure was lower in dapagliflozin versus saxagliptin over 18 to 24 weeks, and further 20 to 102 weeks. So fewer dapagliflozin treated patients required rescue medication, or they had to discontinue the study because of failure to achieve glycemic control at 24 weeks. So in patients with type 2 diabetes, where they are inadequately controlled with high dose of metformin, dapagliflozin was associated with greater durability of glycemic control than a good DPP4 inhibitor over 18 to up to 102 weeks. Type 2 diabetic patients are often overweight and obese. They fall for the higher BMI criteria, and they have other associated comorbidities like hypertension and dyslipidemia. These patients have a higher risk of developing a cardiovascular or renal complication, which leads to cause of morbidity and mortality and increases the all-cause death. Beneficial effect of SGLT2 inhibition extend beyond glycemic control, and like I said, it improves blood pressure, body weight, and lipid levels. The extra glycemic benefits are seen with both low dose of dapagliflozin and of the maximum dose of dapagliflozin. These are 500 patients who were on metformin, again 1500 milligram per day. The HbA1c was above 7, below 10, and they were randomized to dapagliflozin either 5 or 10 milligram as add-on therapy. If you can see, the body weight reduces by 3 kg, as well as the blood pressure reduces by 4.5 millimeter per hcg, systolic BP by 5 milligram. And as we go to the right side of the screen, if we give 10 milligram to the patient along with metformin, the body weight reduces same 3 kgs, and the blood pressure changes to 5.3 millimeter per hg. All the guidelines you take, they promote SGLT2 as a first-line therapy. In Indian population with type 2 diabetes and high burden of poor glycemic control, SGLT2 inhibitors form a vital value addition to the armamentarium of glucose-lowering agents, in addition to the already available popular DPP4 inhibitors. First, it was The cost is also a limit, now no longer a limitation for use of these molecules. If you see the ADA 2018 and EASD guidelines, SGLT2 inhibitors are recommended for patients with or without established atherosclerotic CVD. It is approved for patient of CKD also, up to eGFR as low as 30. The SGLT2 inhibitors are recommended with patients of type 2 diabetes and heart failure to reduce the HHF, MACE, and CV death. They are recommended to prevent progression of CKD. Patients with foot ulcer or high risk of amputation should be treated carefully with SGLT2 inhibitors. And now the latest studies are showing that they don't increase the risk of amputation as well. The 2020 AAC or ACE guidelines include SGLT2 inhibitor for patients independent of glycemic control. It can be used as monotherapy. It can be used as entry HbA1c above 7.5, or for patients above HbA1c above 9 as well. You can use it as a monotherapy or as an add-on therapy to metformin or any other agent. You can add along with insulin to intensify the therapy, and actually adding SGLT2 to patients who require insulin, who are obese, actually requires less insulin than origin. So you can add SGLT2 inhibitor at any point during the course of action, and you get the same result. SGLT2 versus CV outcomes. Dapagliflozin is the only SGLT2 which has shown benefits on sugar level, heart, and kidney in specific patient population, and even in non-diabetic also. It's one of the most well-researched molecule with DAPA-HF, DAPA-CKD, and DAPA-MI. The DAPA-TIMI study, the DAPA-TIMI study results were very impressive. The sample size was 17,000 patients, and the median duration of follow-up was 4.2 years. They were randomized to 10 milligram of dapagliflozin daily versus placebo, and almost 13% of these patients were Asians. The primary safety endpoint was to have no increase in MACE events, and primary efficacy endpoints were reduction in hospitalization from heart failure or CV death. So this was the largest study when it comes to SGLT2 inhibitors and CV safety. The analysis of multi-institutional electronic medical record database, and the risk of cardiovascular events was similar between dapagliflozin and empagliflozin new users, but dapagliflozin may have a better outcome in reduction of heart failure. I guess one slide is missed in between, sorry. So the DAPA-TIMI actually showed that it reduces, no, here it is. It reduces 27% reduction for hospitalization and 17% reduction in CV death. So it helps. Burden of heart failure is rapidly increasing globally, and it is projected that by 2030, number of patients with heart failure would increase by 25%. Mortality rate is approximately 50% at 5 years from initial diagnosis of heart failure. Recent estimates about incidence of heart failure in India vary widely from 1.3 to 23 million patients. Large clinical trials involving patients with type 2 diabetes have shown that SGLT2I reduces the risk of hospitalization for heart failure. They slow the progression of cardiac and renal disease, regardless of the cause and independent of the presence or absence of diabetes. You can use this as a first-line therapy to reduce the risk and to have the primary prevention from any cardiac events. Investigators of DAPA-HF trial aimed to prospectively evaluate the efficacy and safety of dapagliflozin in patients with heart failure and a reduced ejection fraction regardless of the presence of diabetes. The defined HF trial was investigator-initiated multi-center randomized controlled trial, and 263 patients were randomized to dapagliflozin 10 milligram daily or placebo for 12 weeks. The patient profile had low ejection fraction patients, and EGFR was more than 30 and elevated natriuretic peptides. The outcome was meaningful improvement in KCCQ overall summary score, and it was beneficial in heart failure patients with or without type 2 diabetes. DAPA-HF results, there is a reduction of 26% in primary outcome and 17% from death of any cause. So it reduces the all-cause mortality. It reduces the death from cardiovascular causes. It reduces the chances of hospitalization for heart failure. So the meta and emperor reduced, when you compare it, DAPA-HF to emperor reduced trial, that there is no mortality benefit in emperor reduced trial. So they both are equally efficient. The strength of DAPA-HF trial is the benefits are observed on top of excellent background therapy. 94% of patients were on ARNI, ARBs, or AC inhibitors. 96% were on beta blockers and 70% on MRAs. The curve separates rapidly, indicating that patients can derive a benefit soon after treatment initiation. Number needed to treat was only 21 over 18 months, supporting a large absolute risk reduction. So as early as you can start SGLT2 inhibitor, it's beneficial. The results were internally consistent and p-value in addition to evidence of mortality reduction. Post hoc analysis, the benefits seem to be consistent in those who were users of ARNI therapy, which is the last reported class of medication that reduced heart failure mortality. Efficacy was independent of glycemic status, extending the use of dapagliflozin beyond diabetes to patients with heart failure and reduced ejection fraction. The impact of DAPA-HF trial is SGLT2 inhibitor has found its place in the foundational therapy along with ARNIs, ACIs, ARBs, MRAs, beta blocker, and now the fifth parameter is SGLT2 inhibitor. We have seen that dapagliflozin works good when we are talking about primary or secondary prevention of cardiovascular disease. But how about kidneys? The kidneys are equally affected. So the prevalence of CKD in different regions of India ranges from 1 to 13%. And the current study reported the prevalence at 17%. Parts of states of AP, Orissa, and Goa have high levels of CKD of unknown etiology, and it varies considerably throughout India. Patients with CKD have a high risk of adverse kidney and cardiovascular outcomes. CKD is an important contributor to illness and is associated with a diminished quality of life and reduced life expectancy. SGLT2 inhibitors decrease HbA1c levels and have shown favorable effects on kidneys, cardiovascular outcomes in large clinical trials. DAPA-CKD, this was presented in 2020 ESC, and the trial actually had to stop early in March 2020 because of the clear efficacy. If you see in the data, there was 34% patients who were Asians. This study was done in 21 countries with 386 slides, and patients had eGFR ranging from 25 to 75 ml per minute. The median duration of follow-up is 2.4 years. The results are a 39% reduction of primary composite outcome, which was sustained decline in eGFR more than 50%, reduction in ESRD, so the progression, and death from renal or cardiovascular causes. There was a 44% reduction in renal specific composite outcome. That was sustained decline in EGFR, reduction in progression to ESRDs, and death from renal causes. The composite, there was 29% decrease in composite of death from CV causes of hospitalization for heart failure, and 31% reduction in death from any causes. So it improves the quality of life, and life expectancy is improved. There was a 34% reduction in chronic dialysis, kidney transplantation, and renal death. There was no notable excess of any volume depletion, renal adverse event, fracture, amputation, major hypoglycemia, decay, and Fournier's gangrene. So there was no excess of any adverse event. Decay was also not reported in any patients who received dapagliflozin. Neither diabetic ketoacidosis or severe hypoglycemia was observed. There was no evidence of Fournier's gangrene, and amputation and fracture risk was comparable to placebo. So initially, when the canvas was launched, we all had our doubts for Fournier's gangrene, amputation, and risk of fracture. But now, as we are moving ahead with other SGLT2 inhibitors, it is becoming clear and clear that they are safe. So the upcoming trials, those whose results are awaited are DAPA-MI. There is DELIVER trial, determine reduced with reduced EF, determine preserved with preserved EF, preserved HF, and DARE-19, which is for respiratory failure in patients with COVID-19. So to conclude, dapagliflozin belongs to the most recently developed category of oral anti-diabetic drugs known as SGLT2 inhibitors. In addition to improving blood sugar levels, recent promising data presented at international and even national conferences, also published in reputed journals, have confirmed beneficiary effects of dapagliflozin are on heart and kidney too. Dapagliflozin exhibit extra glycemic benefits, examples of reduction in blood pressure and improvement in lipid and weight. They exhibit lower incidence of side effects such as hypoglycemia, which is most common side effect of some of the currently available anti-diabetic drugs. Dapagliflozin has also shown to cause some amount of weight loss. The weight loss is 3 to 5 kgs, sustained weight loss, which is also beneficial in patients with diabetes. Actually, one of the very good study was done where they have shared the result that if you start SGLT2 inhibitors with high BMI patients, the weight loss is rapid and more. So dapagliflozin strengthens current armamentarium of oral drugs used to treat type 2 diabetes, and this has emerged as a cardio-renal game changer. So not only we are looking at a bright future for this molecule, but the cardiologists and nephrologists are also coming for that. So I thank you, and I'll stop the share. Yeah.
So now I would like to request all the participants, if in case they have any question, kindly write down onto the chat box.
I don't think so there will be any questions.
I
because
dapagliflozin
actually checks all the boxes.
Yeah. And it is so nicely explained by you also, ma'am, that I don't feel that there is any query by my colleagues.
Yeah, I don't think so. It is how I present it, but it's the beauty of the molecule itself.
Agreed.
That I doubt that any diabetologists have any queries or concerns over dapagliflozin. And with the price reduction, we are seeing more benefits because we can see the practical usage of dapagliflozin have increased.
Yeah, agreed, ma'am. Agreed.
So it's a wonderful molecule, and I thank TASMED for bringing it to us.
Yeah, ma'am. We have one question, ma'am. We just had one.
The role of kidneys in glucose homeostasis. Okay. The excess sugar is always removed by kidneys. So the primary and distal tubules get the essential glucose back to the blood. It is a physiology that whatever is important to the body, the kidney always try to bring it back, be it sodium, be it potassium, be it protein, anything that is important. So by the same mechanism, the glucose that we consume that goes into blood, even if it is high, the kidney is bringing it back. How SGLT2 inhibitors work is they block the receptors, so the extra glucose which should be thrown out of the body is thrown out of the body, and it does not enter back to the bloodstream. So it improves in glucose reduction, overall HbA1c reduction. It works well with fasting blood glucose levels as well. So whenever we see a patient of diabetes, we usually check fasting PP to be its HbA1c. We want a molecule that is effective not only on HbA1c, but gives us a good reduction of fasting blood sugar as well. So any SGLT2 molecule, they work better on reducing the fasting blood sugar levels and reducing the overall sugar levels throughout the day. The only drawback of using an SGLT2 inhibitor is natriuresis. So the patient will have to go to urine more frequent than usual days. Usually 2 or 3 times, not more than that. So if you explain this to the patient when you are starting SGLT2 inhibitor for the first time, that okay, you will go to urine more and you have to take care of personal hygiene, but your sugar levels will be less. So they don't mind going 2 times extra.
Agreed, ma'am, because this is the beauty of this product, that it is not going to make their blood glucose level onto a higher side. So
Sure.
really agreed that going 2 times extra will not mind to our patients.
True.
Right, ma'am. So we were having only one question into the chat box. So can I give a closing note to this, ma'am?
I recommend using SGLT2 inhibitors where it should be used in patients of type 2 diabetes, those who require insulin, those who come to us with obesity. You can use this to patients who have known case of CVD or CKD as well. So it's a very well researched molecule, very well used, and we see SGLT2 inhibitors becoming the next big thing in diabetic management.
Yeah, ma'am, agreed, ma'am.
Yeah.
So with this note, we would like to thank Dr. Nimmi for joining with us today. It was really an insightful discussion for us as well as for our listeners. I would also like to thank all the doctors for being with us and for their active participation during the session. Thank you everyone for joining with us, and thank you, Dr. Nimmi, for your kind time for us, ma'am.
Thank you.
Okay, thank you, ma'am.